Welcome everybody.
Thinking I wasn't coming.
Hello. Thanks. Hey, welcome everybody. Thanks for coming today. My name is Tom Walsh, and I'm a partner here at Ice Miller. Welcome to our conference area, and thank you for coming to this second session of our Indiana Opportunities to Lead in Digital Health seminars. Hopefully, those of you who were in the first session found it valuable enough to show up again, and those of you who are here for the first time, I hope you enjoy it today as well. You came in through the elevator lobby here. Just quick logistics. The ladies' room is down. It goes past the receptionist desk down the hall. It'll be on your right. The men's room will be through the elevator banks to your right. And I think that's all I'm good for today. I'm going to hand it off to Mike Langelier, the CEO of TechPoint.
Thanks, Tom.
Take you through today.
Good morning, everybody. I'm Mike Langelier from TechPoint. Welcome. Thank you to the folks at Ice Miller, Tom, and your team for hosting us here today and being supportive of this community of the health IT and digital health community. Those of you that have not been part of the event series so far, this is the second of three. And again, the really precursor to this were a group of us that sort of said, we have all of these unique assets around life sciences and health, but at the same time we're seeing rankings on how we're doing poorly on wellness, and it seems like we could have more health IT and digital health companies in the space as well. Let's try getting these a couple of these subsets of people together, particularly from the health care space, from the life sciences space, from the technology space, from the payer space, as well as the provider space. And let's see what collisions, what ideas are generated as a result. And hopefully something interesting will come of it. And nonetheless, we'll all leave more enlightened by hearing multiple perspectives about what's going on. The first event was focused on data and analytics. And this second one will be focused on wellness. And the third to come will be focused on personalized care. So today, some of the organizers that have helped to make this happen, Titus from Regan Street, thanks for your time that you've invested in to make this happen. Brad and the HC1 team invested a lot of time into making this happen as well. Today we have two speakers that are going to be coming up and presenting. Titus, do you want to do intros? Wonderful. Thank you, everybody. We'll get kicked off. Titus Schleier.
So, good morning, everybody. It's wonderful to see everyone. My name is Titus Schleier. I am a research scientist at the Regan Street Institute. I'm sorry that you're stuck with me as a moderator again. The other day when we finished, Lauren from TechPoint said to me, you know, you did such an okay job as a moderator. Would you do it again next time? And with that underhanded compliment, I'm like, well, I can't resist, you know. So here I am. It's my pleasure to welcome many of you back and also see some new faces. Let me talk a little bit about kind of what's beyond the series. And this picks up on a question that Nicole Keith, our first speaker, just asked me. She's like, so once these 3 workshops are over, what's Act 2? And so what I would like you to do is help us all think about what is Act 2 of this. So the only idea we had with these workshops was to connect communities together who are usually not spending time in the same room or in the same venues. So if you look around, you'll actually see people from healthcare systems. You see people from the research environment. You see company CEOs in the healthcare space. You see people from the Indiana State Department of Health. We don't usually spend time together. And I think that is one of the big advantages or achievements of this workshop. But as Mike and Brad and Tom and I talked about in our prep sessions, what I'm going to say in a year that we achieved as a result of this workshop. So I'm going to just throw out the question, and at the very end, I will ask you that question again, and then I know you're not going to be silent. So let me introduce Dr. Nicole Keith, our first speaker. Nicole is a research scientist with the Regan Street Institute and the Indiana University Center for Aging Research. She's also an associate professor of kinesiology. Her research interests are physical activity, health disparities, and health equity. And in the category of interesting things that you wouldn't think about that you wouldn't think of about your speaker, she has a son, 12 years old, who is a crack shot with an air rifle. And the other day, he sent me a picture of his first tanned squirrel skin, tanned with the Indian method. So brain tanning. Do not ask who taught him that, but it looked really good in the photo. And his mother tells me it feels really good. So with that, let's welcome Nicole for her talk.
The crack shot didn't come from me, and the tanning didn't come from me. This was all thank you, Dr. Schleier, for teaching my son a new skill. So, the title of my talk is Can We Do Better at Achieving Wellness Leveraging Health Information Technology? And I start by looking at how we're being measured, and I'm using the American Fitness Index. So a full disclaimer, the American Fitness Index is something that was created by the American College of Sports Medicine. It's an organization with approximately 50,000 international members. And I'm on the board of the American Fitness Index. So as you're being critical of the measure, you can be critical of me. But it was funded by the Anthem Foundation, and it was launched in May of 2008. And the purpose of the American Fitness Index is to evaluate population health and fitness status of Americans. We're looking at the top 50 metropolitan statistical areas in the United States and evaluating the population's preventative health measures and their level of chronic disease conditions. The American Fitness Index also looks at community assets and supporting healthy lifestyles through community supports and the built environment, as well as physical activity policies. And the intent of the American Fitness Index is to capture the state of personal health and the availability of community fitness resources, as well as to evaluate the available data at the local level for grassroots advocacy. So we really wanted this document, and there is an index. If you go online, you can find it. There are print copies available, to serve as a useful tool for people who want to make their communities healthier. The data is based on scientific and evidence-based data, and I'll spend most of my talk talking about whether we did this, or asking you actually to consider whether we did this well or whether we could have done a better job. The data sources that were pulled to use the American Fitness Index included the Behavioral Risk Factor Surveillance System, the Center for City Park Excellence to look at parkland data, also to look at parkland data, the Trust for Public Land, U.S. Census data, data from the U.S. Department of Agriculture, state report cards including school health policies and program studies by the CDC, and then crime data from the FBI. And so if you look at, I have before you the 50 largest metropolitan statistical areas, and Indianapolis ranked 50. And if you want to feel better, from 2014, a high number is, excuse me, a bad number in this case, so it's a little bit backwards from the ranking. And so we went from 47 in 2014 to 50. Our metrics got worse in personal health, community and environmental health, and our total score also got worse. So we went from 47th in the nation to 50. And so when I was talking with Titus about what I would present to you today, he said, we can't depress everybody. He was like, are you going to say something good? Because all this is bad, 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 and this is what we hear about ourselves in almost every index where we're looking at our state's ranking and our metropolitan statistical area ranking as well. So I'm going to say, don't be sad. And I asked you a minute ago to think about how the American Fitness Index did in evaluating ourselves. And so let's think about a world. that we could do better. Let's imagine this world. Let's think about a world where health systems focus on health promotion, and health promotion is embedded into work sites, and health promotion is an integral part of urban planning and community development, and health promotion actually engages all sectors. And you'll think, well, isn't that what Titus just said? That's what we're doing here today. So it's really, you don't have to imagine it. Imagination meets reality today in Indianapolis. And so my lab, he told you a little bit about my research, and my lab is Eskenazi Health Systems. That's where I do the bulk of my research. And I'm really proud of Eskenazi. So how many of you are from Eskenazi? Okay, so 3 of you will say, yeah, that looks familiar, and it'll brag on you a little bit. But on the 7th floor of Eskenazi, there's a Sky Farm. And the Sky Farm grows herbs and vegetables for sale. The Sky Farm also has places, it's got a beautiful scenic view of Indianapolis, and so what you see outside behind me, you can see from the Sky Farm, and people can relax. There are yoga classes that are offered on the Sky Farm, and there are places outside. There are great sidewalks, so those of you who have been to Regan Street Institute, which I'll show you in a second, great sidewalks for walking around Regan Street Institute and Eskenazi Health. And I'll go on. There's great art, and so there's health promotion not only in what people can eat, but also in what people see as they walk through this public health system that's intended for low-income, uninsured, and underinsured individuals. There's a restaurant. There are 2 restaurants actually, and one inside the hospital that's run by Eskenazi, and for healthy options you actually get a reduced price lunch. And then outside, and within that hospital also, within that restaurant also, they use the herbs that are grown. On Thursday, there's a farmer's market that's offered to the public where you can buy the herbs and the vegetables. So lots of healthy choices. There's art in the waiting room. This is actually the main waiting area in Eskenazi. And there's also a grand piano. So it is not unusual, and I was shocked the first time I walked through the new Eskenazi Hospital to hear beautiful music, but there's an invitation for patients and staff who have that skill to play music, and it offers a really relaxing environment. So not just a place for sick care, but also for wellness. And then I would be remiss if I didn't show you the opportunities for physical activity. So there's a splash fountain, and Eskenazi is right across from Riley, so it's a great place for kids who visit Eskenazi as well as Riley to come across and play in the water on hot Indianapolis days. There's also for the staff, and so for those of you who are guests at Eskenazi who may not see this, but there is a fitness center, and you'll see that there's the classic free weights and cardio equipment, but there's also this great cardio room with over 500 videos for people to come in and do classes with these videos. There's a cardio theater, so it's a really great place for health promotion for their staff. So the first thing I said is imagine a world where health systems focus on human health promotion. These health systems currently exist in Indianapolis. Many of you were able to visit our Regan Street Institute in our new building, and health promotion is embedded into that work site. And so all of us have standing desks, and you can see our receptionist at her standing desk. We have them in the offices, we have them in the cubicles, we have them in the reception area, that everyone has the opportunity to stand, and if you're worried, people can sit down too, they lower. So if you have back problems and you need to sit, you can, but it's optional. We also have water filling stations, and it's hard to see in this picture, but it shows how we are promoting the green environment by recycling our water receptacles instead of using water bottles. And so the building was actually built intentionally to promote health. If you look, there are great spaces for walking, and Bill Tierney once told me before he left us, he's not dead, he just moved to Austin, but before he left us, although, anyway, he just moved to Austin, that when the building was being built, they wanted this majestic staircase, and that I won't say how much money, although he did tell me a lot of money was spent on this staircase, so much so that the elevators that were planned to be installed were not installed, because the budget was spent on stairs. And so we have this one crummy elevator, and if you go into Regan Street, the elevator is slow, and there are not two of them, there's only one. And if you start on floor 1 with the elevator and floor 1 on the stairs, and I'm not real fast, but I beat the elevator every time. So there is this incentive, if you're a busy person, to take the stairs and not wait for the one crummy little elevator, which promotes health. We've been in the building since November, and the stairs are getting a little bit easier for me. And then we do have a fitness center that is available for use for all Regan Street employees as well. So then I would be remiss to say that our leaders in our building promote health by active commuting. We have a bike storage, and you'll recognize Dr. Schleier. Many of our leaders in our building do active commute to save fossil fuels and also to improve their health. And so there's health promotion within our work site, and we're encouraged. I showed you on the last slide, there's a shower, and we're encouraged to be active to work, home from work, and while we're at work.
I don't usually bust through the wall, you know.
He's Superman. Okay. We don't like each other at all, you can tell. So around the city, and so I can't take credit for this, but I'm really impressed around the city how we are promoting health as a city. And this is part of Pacer's Bike Share. You probably noticed as you came into the building this morning that Bike Share is available throughout the city. Last year alone, the Bike Share was responsible for 116,000 trips and 240,000 miles of commute. So people are using it. We also have the Cultural Trail and the Monon Trail so that people can actively commute not only around the downtown area or the inner city, but also out to rural communities. And I'm really excited to see how the trail system is expanding so that people who want to actively commute to and from work are able to do so. Health promotion is a part of city planning in Indianapolis, also evidenced by the downtown canal. We see increasing bike lanes. We see evidence of infrastructure that is intended for pedestrians to move about the city safely, and we see many, many more community gardens. And I'll say that on the American Fitness Index, if you look at it, that is where we got better, that we have more community gardens than most metropolitan areas, and many more than we did 2 years ago, so we are doing really well in that area. Also, health promotion is part of community development, and so there are examples of this throughout the city. This is the Near East Side of Indianapolis. This is the Chase Near East Side Legacy Center, and this is offered to people who live throughout the city, but especially on the east side of Indianapolis, which has traditionally been a low-income area. This is a fitness center, and on the other side is a community center. It's a full-service fitness center. These are pictures of students who are from the Department of Kinesiology at IUPUI. They offer group fitness classes, personal training, and other health promotion activities that are free of charge, and there's a reduced membership. I'm a member of the center, and I pay for my family $320 a year for my family of 6 people to use the fitness center. So it really is affordable, and that's the highest anybody would pay. I couldn't get the sliding scale fee, but many people do and are able to work out there at low or no cost. And so my critique of the American Fitness Index and other indices like it is that health promotion is largely based on self-report or on data that is reported by some government entity. And so maybe not the most accurate measure. And so my question to you is, how can we better capture these data? Because I've given you lots of examples of why Indianapolis shouldn't be 50. We should be much higher than that, but there's no way to capture those data, or is there? And so I'm saying yes, there is. And so there are ways, and I have evidence of people counters and trail counters, and even cameras that are used for crime could be used to capture these data of how people are cycling, how many people are using the Monon Trail and the Cultural Trail, how many pedestrians are traveling Indianapolis streets. And I was at a conference last week, and there are systems in place in many cities right now that are using crime cameras to capture pedestrian data. So how might we do that here in Indianapolis? There's a possibility of interfacing health behaviors and health records. In some cases, this is happening, and in some cases, it's not. I have a Kroger Plus card. I also have a Walgreens customer loyalty card, and my more frequently used CVS customer loyalty card. I don't know if any of you are in here, and I'm not promoting either business. I try to be even. I know that Meyer has a loyalty card, Marsh has a loyalty card, and they are tracking what we're buying. They're tracking whether we're buying fruits, fresh fruits and vegetables, and whether we're buying lean meats, and why can't we tie that to the health records? Additionally, I have my Apple Watch. Many of us have wearable technology, and so those companies are tracking what we're doing in terms of physical activity. Right now, also the American College of Sports Medicine has this program called Exercise as Medicine, and through Kaiser in California, the patients are wearing wearable technology and the physicians are prescribing exercise. I'm a little critical, and I'm on the EIM board too. I do a lot for ACSM. But I'm on the EIM board, and right now, how it goes into Epic, Kaiser uses Epic, and how it goes into Epic is the physician asks 2 questions. The first question is, in the last 30 days, have you participated in moderate or vigorous physical activity? And then if the answer is yes, the second question is, if so, how often? And those data go into the medical records. Think about it. The physicians are asking patients to understand what moderate to vigorous physical activity means, and then remember whether they did it and how often. There was and I was up, unfortunately, watching the news last night about how wearable technology is not accurate. However, it's within 3%. The number of steps was in a 3% error. 3% is pretty good. Much better than self-report. And so if we have our patients wearing wearable technology and we can get their steps within 3% and put it in a medical record, I think that that's a little bit better. I'm happy that Kaiser is asking about physical activity and putting in the patient medical record, but I think we can do a better job of capturing these data. And so we have a little pilot going on at Eskenazi with my friend Chris Power, who's in the back. Thanks for coming, Chris. Chris and I are doing a little pilot to see if we can get doctors to prescribe exercise. And we have Corey, you see a picture of Corey in the slide, he's our personal trainer, and physicians refer their patients to physical activity, and Corey, through the wearable device and an app, talk to the patients about walking, just walking. And she does some fitness testing with them, so she has exercises they can do for strength and endurance and for flexibility if they need it. And that technology can interface with an electronic health record, and we would like to see that get put in Epic when Epic gets implemented in Eskenazi. Well, yesterday, and I'll close with this, one of the physicians who's working with us in the study came and talked to me about 2 patients who are participating, and he was so excited because one of his patients not only is being more physically active, but her depression is better, which makes me excited because that was not a goal. The goal was to increase steps and not improve depression. So it's really exciting that we have physicians, and one of the physicians is a psychiatrist, who are really excited about this technology and the opportunity to get patients more active too. And so I said, can we do better at achieving wellness leveraging HIT? And my real question for you is, can we do better at capturing data, integrating those data, exchanging that information, and communicating that information through these indices so that we can make Central Indiana look like the healthy place that it is. Thank you.
Thank you, Nicole. Great talk. We'll take a few minutes for questions. Maybe. Just before we do that, when we previewed Nicole's talk and she started she came to her third slide, you know, we have 50 out of 50, and I'm like, Nicole, don't do that. We did that at the last workshop, and people walked out really depressed. So I said, say something good, which she did. The other thing we did is we laced the coffee with a light antidepressant, just to make sure that you know, we're not too depressed all the time. So lots of stimulating ideas out of Nicole's talk. Questions for Nicole? Yeah.
Cool. Question in terms of this, you sort of showed a whole bunch of things where it looks like we are making changes in terms of this. But what is it, do you know what the key reasons why we are number 50 in the American Fitness Index? I mean, I assume it's a composite score.
Yes.
I mean, where is Indianapolis, you know, worse than the others, or where can we make changes to drive that faster?
So those are two separate questions, and they have two separate answers. So we're rock bottom. I'll tell you where we're rock bottom. The funding for public lands, so our park lands. And part of that is actual funding, but part of it is the way we're measured. And so there's parkland in Lawrence Township that's not counted because Lawrence Township isn't considered part of MSA of Indianapolis, and there's land in Speedway. So there are these pockets that aren't, because of the way Indianapolis Metropolitan Statistical Area works, there are these pockets of land that don't count. But then our funding isn't really great in terms of funding parkland. We're really bad in public transit. I'm not telling you anything that you don't know. Our requirement for physical education in the school system is worse than any other state, and then our personal behavior. And so part of it is that we just don't report physical activity. And so part of my criticism is we're relying on self-report, and maybe Hoosiers are more honest than other people, I'm not sure. And part of it is we're being compared to places like Denver and San Francisco and Washington, D.C. that just have more parks, the ocean counts, and mountains count. And so we just don't have those things. And so part of it we can't change. And so the second part of your question was, what can we change? So funding in parks we can change. We can do a better job of measuring, and we can do a better job of making it easier to actively commute. If we look at some place like Denmark, that this is a normal thing, streets close on Sunday so that people can ride their bikes and walk safely. I think that Indianapolis is doing a great job compared to where we were 10 years ago in terms of bike lanes and in terms of being able to actively walk around. We're doing a better job of building great sidewalks and infrastructure so that people can feel comfortable being a pedestrian or a cyclist. But I think that the Pacer bike system is great. I'd like to see more of that on university campuses, not just IUPUI, but also Butler and University of Indianapolis, so that students can actively commute. This has to be encouraged, and it has to become a way of life for all of us, that people are really biking for their destination rather than for the journey.
Excellent, thank you.
Joe.
Nicole, thanks. Joe Schneider with IU Health. So you mentioned a bunch of different things, and part of all this is the actual, having parks in the ocean and things like that. Don't worry, the ocean will come to the global warming. But the part of it is also data, as you talked about, and getting these things into our records. The challenge that I think we all face is that everybody's trying to do what I would call point-to-point solutions, in the sense that it's called, let me get my patient's Fitbit data or whatever data into my EMR, okay? But we know that patients move around. One of the beautiful opportunities of Indianapolis, Indiana, is that we actually we are far ahead of the rest of the country in the concept of data sharing. And so bringing this data together at a community level and allowing us all to tap into it so that Epic doesn't have to build the interface to the Fitbit. And we use Cerner, somebody else uses Allscripts, and there are a gazillion electronic medical records out there. And what we wind up doing, in essence what we're doing right now, is we're sort of building frequent flyer loyalty programs, which is exactly the opposite of what we want to be doing. So I would encourage everybody to be thinking about how do you get this data into, in essence, call it the person's record in the cloud, and we can tap into that as we need it, but so can everybody else that needs it.
I think
So,
that's
appreciate it.
incredibly important. Thank you for that comment.
Which picks up the idea from last time when Nehemiah Kenny said the Indiana Network for Patient Care is a sick data system and it needs to be a health data system. So we'll come back to that question because now we've validated it in the second session in terms of how do we get that done. Other questions? Yes?
I'm Michael McClellan, Ball State University. So, talking about the incorporating the fitness trackers into the EMR. So, is that something that would just work with off-the-shelf fitness trackers like a Fitbit or Apple Watch, or is this a proprietary system? Because I was wondering, like, if I have a Fitbit and I go in to see my physician, can he just capture the data that's on my device and upload it into the EMR, or do I need to be provided with a proprietary device to capture that?
Absolutely.
So thank you for asking that question. It allows me to kill two birds with one stone. So Nicole was wondering about integration of Fitbit data with Epic. And so Epic actually is one of the EHR vendors that's fairly far along in the journey to integrate many data. So it's not just Fitbit data, Jawbone, all the different devices. They also integrate automated blood pressure cuffs, glucometers. And so Epic actually has a good portal for that. I just saw that the other day in Verona. The other question you ask is, should this be a one-off thing? And the answer is clearly no, because that creates a lot of work. So you have middleware companies like Validic, for instance, maybe Rod, you probably are an expert in this. So I should actually pass this question off to you. What am I doing here talking about this? But anyway, it's, there's a plethora of devices out there. New devices are coming online essentially weekly. And so healthcare settings shouldn't worry about how to get it in. It should be companies that specialize in aggregating data from multiple devices. You want to add something to that, Ron?
Most of the new technology companies on the wearable space have all open APIs, so you can virtually grab an open API within hours and start consuming data. The issue is personal privacy and getting permission from the individual to get the data.
Okay. Other questions? John?
I guess I just make a comment and invite people to rebut, I guess. I'm from the Indiana Health Information Exchange, so I agree with Dr. Schneider's comment about putting the information where it's most accessible. I'm also a recovered biomedical engineer. And when I think I hear about Fitbits and Apple Watches, I'm kind of waiting for them to capture more relevant clinical parameters. So I'm being a little skeptical here in terms of what we can capture today. I read an article, I don't know if this is still the case, that Apple was planning to have two versions of the Apple Watch, one which was FDA approved and the current consumer Apple Watch, because for the Apple Watch has the technology to be able to capture more relevant clinical parameters, but they disabled those features because it would require the device to be FDA approved. So to me, I see the linkage between this data being generated and this data being captured in the medical record, but I think the conversation becomes more interesting when there's other relevant clinical parameters, HR, blood pressure, pulse oxygen saturation in the being captured.
So I'm going to push back a little bit because I think physical activity, although it isn't a clinical parameter, it's a really relevant parameter because physical activity affects so many other health outcomes. And so if we can intervene on physical activity by capturing physical activity, that's important. So that's why my professional organization is making this push to make it part of the medical record. I don't know that I would ever want physical activity to be considered clinical data because it's something that people do like breathing. We would like people to be physically active. But I understand what you're saying, but this is one piece that I think is very important. And in terms of tying it to health outcomes, it will teach us a lot more about how people behave and how that can impact health. So I would encourage you to consider including physical activity data in iHigh if we can get it, if that ever becomes a possibility, because it will tell us a lot about other health outcomes.
Okay, last question.
Megan from Eskenazi Health. I was just wondering, is there any tracking going on with how many physicians are prescribing or giving exercise prescriptions, or any incentive for them to do so?
So you're probably familiar with the program Healthy Me, which is it's about 12 years old, and it's a weight management program. It started as a weight management program, and now it is also an employee wellness program within Eskenazi. And it allows, through the electronic medical record, patients to refer, or providers to refer their patients to this weight management program. And now employees can use it too. That's the only tracking. So if a physician is saying you should exercise, we are not currently capturing that. The only thing we can capture is that referral. And it is incredibly low.
I sense an opportunity for natural language processing. Alrighty, on that note, thank you very much, Nicole. And it's my pleasure to introduce Dr. Julie Daftari from United Healthcare. Julie is the Market Medical Director for Indiana and Kentucky, and a family physician. And again, in the spirit of things you don't know about your speakers before you talk to them, when we talked about Kylan's, Nicole's son's exploits, Julie said, he might like meeting my son who brought a deer head to church the other day. So on that note, let's welcome Julie.
The deer head did not make it to church, but we were late to church, I would say. So. All right, so what if a wellness solution doesn't lie with a healthcare provider or a healthcare system? What if we can make a difference before someone even steps foot into a physician's office? I toyed a little bit with the title of this presentation and actually changed it from patient engagement to consumer engagement, because what if we can empower a consumer before they become a patient? To make a difference in health and well-being, it really all comes down to individual behavior. And research tells us that up to 85% of all diseases are associated with modifiable health risks. That means that they're preventable. And to make a difference, we have to choose to make those changes ourselves. So I'm going to focus on employer solutions for a wellness program, and really how can we drive that personal responsibility and personal accountability. Employers are really starting to understand the value of investment when it comes to an employer-driven wellness model. With that value of investment, we see reduced employee health risks, which can reduce healthcare costs, and ultimately lead to improved employee productivity. Makes a big difference for an employer's bottom line. So what are the keys to a successful wellness program? One of the most reliable measures is actually employee engagement. And communication is key to making that happen. So the more engaged an employee is, the better the outcome with that wellness program. You can see here some of the potential communication channels that are currently utilized. So what we'll focus on today is really what's available in the market today, and really the question would be, where can that go tomorrow? So what is the opportunity? It's estimated that 90% of adult Americans have cell phones, and 64% of those cell phones are actually smartphones. The only reason it's not higher than 64% is because we see that significantly drop off at the age of 64 and beyond. But you can see that this can be a powerful mode of communication and disseminating information. With portable devices, not only do the vast majority of Americans actually own these devices, but they describe themselves as not being able to live without them. You can see here the statistics, 67% of adult Americans actually check their phones when there's not even a ding or an indication that they need to check the phone. So they're on the phones all the time, so it makes it a very powerful means of communication. So how can we best leverage the use of technology with employer-sponsored wellness plans? Really, you have to understand the target population. And when you are able to target that population, really show how the program can benefit that person's health, outline the incentives and rewards that that person would receive from that wellness program, and include a clear call to action. That clear call to action is key to improving the engagement of the employee. So what are some of the individual opportunities? Email, probably the simplest, easiest form of communication. Really, it's a very effective means of communications on a large scale. Really, you can see here all of the information that can be disseminated by email. Some examples of some email in action. This is what an employer could send to employees. You'll notice that the emails begin with real attention-getting statements, very engaging with the color. So marketing is just as effective or just as important as the means of communication. And with all of the communications, there is generally a click here, some type of call to action, some action that needs to be taken. Next opportunity would be social networking. Many of you also would probably agree with this. Could be a very effective means of communication. Prevalence has increased significantly over the past few years. And you can see the majority of Americans use social networking, with Facebook being the most popular. Social networks really offer limitless possibilities to engage individuals and can be a great platform for really being encouraging and supporting to that individual person's fitness goals. Here are some actual Facebook posts. These are from Source for Women and the United Healthcare Accounts. Not promoting, just examples of what is available. Again, you can see that there's vivid graphics and really can be engaging for individuals. Again, social networks can be a great way for communities to evolve with great support systems. This is actually an example of United Healthcare sponsored wellness program called Rally. This platform is very good for engaging individuals to become involved and be encouraging to others. Next opportunity would be web portals. Web portals can offer another means to help improve engagement. This is actually a screenshot of United Healthcare's intranet site. The landing page has sections outlined at the top for easy navigation. You can also see quick links to the right, and there's also embedded videos on that particular site. And again, it's really designed for easy navigation for employees to really become engaged. Another example of web portal, you can see again here vivid titles for these individual icons with a clear call to action with those learn more buttons. Again, web portals, endless possibilities with widgets that can be added. Not only are there supports for continued behavior, healthy behavior, but also resources for quality and affordability can really help members make informed decisions. Videos also can be used, can be very engaging, shouldn't be too long, and again, really can relay the message that you are trying to send. The opportunity apps. Apps, everybody loves a good app. Very easy to use. Not only can consumers have instant access to whatever the wellness platform is, but again can have access to quality and affordability resources to help them make informed decisions. Good old-fashioned TV monitors still shouldn't be dismissed. It's a good way to loop your message and have that in front of people on an ongoing basis. Can be customizable to the actual employer, so it makes it relevant. It's also a good way to help remind the employees of upcoming events and ongoing initiatives. Don't forget traditional channels. Really, the goal would be to reach 100% of the population. And again, we saw not 100% of the population might have access to some of the technology tools. So really don't forget print matter, still very important. Good old-fashioned mailers and employer meetings. So even though incentives may help drive participation, it's not all about incentives when it comes to a good wellness platform. We really want to identify overarching messages and really demonstrate that that the organization wants to empower the individual to make those healthy changes. And at the end of the day, it might be true what they say.
Question for Julie.
So Jim Murray, Eli Lilly, I guess this is a question perhaps both of you. Because clearly what you've demonstrated is the power of sort of social messaging, being able to do that. But I wondered to the earlier question about the data, about social listening, because the data is really messy, but there is a signal in there that could actually tell us a whole lot about who people are. So to your point about self-reporting, I wonder if there's been any exploration of the potential of social listening to see what really are the trends, what is people's individual journey, what are their issues, to be able to understand that.
Well, I can tell you from a United Healthcare standpoint, the wellness platforms that we present for an employer solution, that information is tracked, and that's actually how we measure the success of that particular program. We do measure the data because we are a payer. We can also monitor health outcomes, which really we can really demonstrate that value to the employer. So that's not to say that a payer-sponsored wellness plan is the only option. I think that's why we're here today. Not to promote United Healthcare, but really, it's really any wellness platform. You'd really need to be able to measure that those health outcomes.
We call it a meeting, but if you start tapping into Facebook and Twitter and all of these, which they do have APIs, and there's this ability, it's startling.
Yeah, so I just read a study on Sunday that speaks to your point that on social media, and this was specifically Facebook and Twitter, I don't know about the other forms of social media, that the treatment requests or the treatment language, the treatment messaging on Twitter and Facebook is 3 times that of the health promotion messaging. And so that is being monitored, and one of the goals is to turn that around to have more messaging towards health promotion and less towards treatment. So yeah, it's being monitored. I don't know, I can't tell you who, I didn't say, well, is this a reliable study? I just read it and said on social media and said, oh, that's interesting. So there are people who are monitoring it.
Actually, I wanted to follow up on the question of ROI. I don't know how long you've done the wellness programs for employers, but what is your average ROI? What do you tell an employer in terms of, okay, this is how much healthier people are going to be?
Really,
after
the message
X?
is really getting away from ROI and really more what's the value of investment, because the value of investment is so much greater than what the ROI could ever calculate, because you see improvements in things that aren't monetary, that actually end up affecting the bottom line. So again, it's all of those, it's decreasing disability claims, increasing productivity, decreasing sick days. There are a lot of other things that go into it. So really the focus more is on the value of investment, the overall value of investment, and less on the ROI.
Somebody had their hand up?
I did, but just a follow-up, and he actually asked it.
Other question? Right.
Well, I just want to put a plug here based on some of the questions for qualitative research. A lot of what we do tends to focus on the quantitative, where we're looking at big data and doing analytics. But to answer some question as to how do patients traverse a wellness program or a healthcare program or a sick care program, it can be found in the qualitative literature. And so I just want to sort of plug here to think about that. So as we think about measuring things, we need to think beyond just sort of quantitative numbers and think about profiles and scenarios and interviewing people to get a lot of those data. Stuff is well done studies, but that's how we can learn the impact beyond and start to understand how to use these data. Right, so we're still in the early days, I think, of figuring out, even if we could plug in a lot of these devices into the EHR, how would physicians use them? How would they fit into a typical 10-minute primary care visit? We still don't quite understand if we can figure that out.
Joe.
So 2 questions unrelated. Very first one, you mentioned apps. So Ochsner is a healthcare system in Louisiana. They rate apps as to effectiveness and things like that. And going back to my earlier comment, each one of us as a healthcare system, IU Health, Community, United Healthcare, Anthem, we can all do our apps ratings, and we could confuse the heck out of people. The Indianapolis, is, as I understand it, is all about cooperation on these sorts of things. What are your thoughts about getting together with Anthem and other sorts of organizations and actually developing some sort of rating system for apps, just as a thought?
In theory, it would be great.
Of course.
We run into confidentiality issues really with some of that information.
I'm talking about grading the
Oh,
data
what
in
grading?
the app, but just the effectiveness of the app. We all know they're really good apps and they're really lousy apps. So rather than each of us.
Yeah, I mean, I
having-
think it's still, I think we're still very segmented, that goes back to what some of the problem is right now with technology, is that everybody still does their own thing.
Exactly.
So really it's brainstorming and coming up with ideas that really can make the healthcare system truly integrated. In a truly integrated system, we don't have, not everybody's doing their own thing.
Right, yeah, okay, so that would have been one thing. The second thing was that you collect a lot of information as United Healthcare. So we have physicians, community, others have physicians, that you try to get that data to us. But going back to my previous comment for the earlier speaker was that's really the patient's or the person's information in a sense. You're not legally like under HIPAA it is, but I understand it's the insurer's information. But I have a pitch that says we shouldn't compete on information. And so the ability to share that information about fitness and about other things at a community level so that we can all draw from that. United Healthcare, Anthem, all of us are a part of that activity. And if we really want to move the Indianapolis needle from 50 to number 1, which is I think what we should all be about, I think we have to do something like that. And in in essence, stop, we're probably not consciously competing on information, but effectively we are. So I just offer that as a thought and an opportunity.
Dan Robertson from Indiana Biosciences. I just want to follow on with that as I keep thinking about this as well, in terms of it really comes back to sort of the exchanges, the open standards, the open information, the APIs. Apple's making a play with the research kit. Google has Google Fit. Other people are having this that actually acts as an integrator for the information. Coming back to me, the challenge is if we always put it into the healthcare provider perspective, provider base, we're missing a whole bunch of the information that in terms of that. And it really comes back to it's the consumer information, it's the patient information. And so how do you flip it back to there and say, yes, we do want it exposed to the medical provider, but much of this needs to be captured, as Nicole said, in a different form. And so if you had a way to do that, there's a great example, I think, emerging now as you go to continuous glucose monitoring and all the various devices out there that are doing that, as well as the insulin pumps or anything. There's a not-for-profit that's starting up to actually aggregate a lot of that information from the devices, patient-provided, because they want to help actually people understand this. And then it becomes available for other organizations to be able to do research on that. And there's actually a commercial entity who's trying to do the same thing. But the question is there something in here that you actually could do that, to aggregate, have some open standards, to be able to do that, to gain, not necessarily compete on the information, but how you use the information to improve people.
I love that idea. I love the idea of gathering information, and I alluded to it in one of my slides that it's not just wearable devices, but also what else we're being tracked. And I do understand that it's the person's information, but as people seem to be willing to be tracked. I'm willing for Kroger to know what I buy so that I can get coupons, same with CVS, and people seem to be willing to give up some of their personal information in order for personal benefit. And I wonder how many people, and I suspect that the percentage would be rather high, how many people would be willing to give up their personal information to some collective unit? I don't know who that, maybe that's us, that would monitor that information to benefit population health.
So key point on that, right? The only person who can't be, have a HIPAA violation is the patient themselves. And I talked with some of the younger generation just on this summer, and it was interesting to me, they had said exactly that thing, is saying, actually, they don't mind giving up some of that if they have a benefit back. If there's value provided to them, now they see the risk versus the value as a different proposition.
Sure.
So I like a lot of the comments that have been made, and I really appreciate what the presenters have spoken about. I'm hearing a theme that I just want to surface and crystallize, and that is speaking as a physician, a family physician, and a biomedical informatics research scientist, and a propeller-headed geek. I got into informatics over 15 years ago because I thought I could spend all my day working on technology. And the reality is I spend less than 5% of my time on technology, because the initiatives that we're talking about here are not about technology, and I hate to sound like I'm minimizing the role of technology. Absolutely important, but 95% of the critical success factors are social, political, economic. And so I hear us talking a little bit right now about how do we align interests, how do we align needs, and I'll just say, the health information exchange that we have in Indiana is the country's largest, the country's longest running, and that was achieved because a group of people back in the late 1990s got together and said, you know what, our interests are aligned, we need to do something great here. The technology followed from that. This has never been about technology. It's been about aligning interests. So there's unquestionably bringing that patient data, that patient perspective into this space. It hasn't been done yet at scale anywhere. And we exist in a community that already achieved something that few others in the country have achieved. So how can we focus our conversation, again, I'm a biomedical informatician and a technologist. How can we focus not on the technology, but how to align our needs so that we can build something? The technology will be there, but I think it's going to be really important that we think about aligning those interests and moving forward in that way.
Thank you, Sean, for asking the hardest question of this morning. If Sean hadn't asked it, I would have asked it. This was going to be my, big mother of a question to you all, because I think we have a very good outline of the vision, but the question is, well, how do we take the next step? How do we make it real? And so we have the key players in the room. We have John Kansky from iHide, we have Regenstrief, we have the health systems, we have patients, we have ourselves. We are the people whose data will make it into that repository. But right now, we don't really have anywhere else in the country, as far as I know, where a health information exchange or a community data resource integrates patient-generated data at scale. There are pilot projects in places, but there's nothing of the sorts we're talking about today. And I think it's one of those moments where we can say, we can either lead or we can let this opportunity pass by. And I would rather have us walk out of this room today and saying, we will lead this. And I don't expect a final answer to that question, but I'd be interested in hearing your thoughts. How do we make that happen? Because it's a question of money. It's a question of the business case for it. It's a question of benefits to various parties to all of this. How do we make this happen? John.
Trying to take to heart what Sean just said, which we experienced, is what if we put cultural change and policy in the lead? The next conference has policy and cultural change in the lead with technology as an enabler. So and if that sounds a little too warm and fuzzy, I can tell you that reimbursement changes in the healthcare system are causing alignment of, for example, I like to say that like ACOs are putting hospital systems and the public healthcare system on the same team for the first time in 100 years. And so there's things that make that viable. So what could that look like? Well, if we align hospital systems, payers, the Regenstrief Institute, IPRI, I'm not trying to cast a wide net, and said, okay, we need to influence policy in Indiana. We need to talk about what big things would create cultural change in Indiana. Now, how do we use technology to make that cool or feasible? I mean, I'm thinking about if we invested in more public trails, great, that's awesome. Now, how do you get people to use them? If the technology would have to pick this up. If the technology made using the trail cool because there were sensors on the trails that were linked to your an app in your pocket as you went by, and hopefully think about yourself, maybe that would be a crazy idea, but just trying to make the point. Let's lead with policy and cultural change.
Other reactions, suggestions?
What are those policy or partnership barriers? You're asking the technology guy?
I mean, one of them is personal privacy. So we've done for every study where you ask young people, are you willing to give up some of your data into the cloud so that you can track your own fitness? People say yes, and then our colleagues done IU that survey people in rural parts of Indiana and other parts of Indiana where they say, I don't even want certain physicians to have my data. I want to personally control every little bit of data down to the LDL versus the A1C level. And so if we're talking about a system that scales, we have to think about how will we get consent, right? So if we're going to connect Kroger data with Walgreens data, with VA data, with IU Health data, with Esteban's data, with people's personal trackers, right? So we have to think about consent on all of those levels and get all of that to align. That's not easy. Could it be achieved? Yes. It'll take a lot of effort. So that's one of the big policy barriers. And then
Let me just briefly respond to that. So I think those concerns are real, but we also don't need to boil the ocean on day one. You know,
Right.
whenever I think of projects like that, I'm always thinking, what can I do to make the context as biased as possible in favor of success? So judging from what you just said, it's got to be in a city, can't be in a rural county. You know, it's got to be with people maybe who are in an employer-sponsored wellness program. You know, so you set yourself up for making a bridgehead, and then you know the countryside will eventually follow it if you want. You know, somebody else had.
David Wolf from Ball State. Going along that with the issues of confidentiality, is the intent to try and have identifiable information or just aggregate information from all these different sources?
But it depends on if we want accurate data or not. So if you just simply take, if you think about how many portals and devices and everything you have and are all of them synced to the same user profile, and so if we want to have accurate representation of how healthy are we, then we have to be able to duplicate across individuals. And so you can't just go and grab an aggregated data set from A and B and then combine it without being able to deduplicate.
I might say to the question of aggregate versus patient-centered is one of the use cases as well. So what do you want to do with the data? There are some things you cannot do with aggregate data that you can't do with patient identifiable data. And I think that's probably part of a strategic discussion.
And the bottom line is the Indiana Network for Patient Care is an identified repository of healthcare information. You know, all of us, I would suspect, or most of us, are in the repository. All of our information is connected and it's identified, but it's also kept very secure.
So Titus, to follow on that, I think it's not just the consent, but where you come back to in terms of this as you're going into social media, or you're going into other type of Fitbits or data sources where it's not necessarily identified. How do you link de-identified back to that individual, sort of like you do in the credit industry or otherwise, where now there's a mechanism or means without necessarily having to expose personal information, but still have a mechanism to allow you to do that, identified link, so that if you do have a use case where you need longitudinal data or understand a broader individual, you can do that. Otherwise, if it's population dynamics, then you can do something a little different. But I think ultimately that not only the consent, but I think the linking of that uniquely back to the individuals to deduplicate and do some of those other things would be a critical hurdle as you go forward.
Other suggestions, questions? Yes.
I guess, taking the themes in terms of sort of cultural change, well, really teasing out some of the questions, because we always jump into the data, and the data stinks. It always does. It's never perfect. So the question, really, what are the key questions or key barriers? And then how can you not let the perfect get in the way of the good, but get an answer that's good enough? Because we probably, even with noisy, messy data, if there's a huge signal there, that can help us maybe not answer the question perfectly, but with a reasonable degree of uncertainty, then it might be actionable to drive policy changes, cultural changes, or whatever else we might want to do. And I think it really does come down, so often people go, well, what's the data? And we're trying to drive people to say, what's the question?
If I could amplify what you're saying, violently agree with what you're saying, but I want to reflect it back in a slightly different way. Historically, the folks who we work with who consume data for a variety of purposes had expectations that that data was hand curated, manually collected, validated, etc. When you think about observational clinical data, to the gentleman's point, it's messy. Now, I would go so far as to say it's god-awful horrible, but it's messy. And understanding, so part of the challenge in moving into a new era is saying, okay, we have a variety of different data sources from many different locations. What potential value can we derive from them? And educating these folks who had prior expectations of pristine, doubly validated information. Because we're showing, we've got lots of studies published for the world to see of the value that can come out of less than perfect data. And I think that's a dimension of this, is setting expectations for the consumers of that data to understand it isn't perfect, but it has value. And I can tell you with some of our partners, it took 2 or 3 years to get them to that point. We knew there was a value use case here, a value to them. And when you first presented, there was this challenge of, well, it's not like we have it today. It's different. And you continue the dialogue and you continue to show value and eventually say, oh, okay, we get it. And I think that should not be lost on this conversation, because that's an important part of transitioning to data like we're talking about, systems like we're talking about, is different than going out. Brian has a great presentation where he talked about, from the hunter-gatherer phase to the agrarian phase, right? In the old days, you went out and killed your own data. In the new phase, we're an agrarian society, you cultivate data together. And that's part of the cultural shift internally within groups like this. The cultural shift, there's another cultural shift outside of the external people who are contributing data, the patients, the external administrative consumers of this have to get on board as well. So there's multiple cultural shifts we're talking about.
And going forward, I'll just say, because I think about this, my colleague, there's always, I wish I knew. Because once you say, I wish I knew blank, then you can start talking about somewhere between the data, the design of whatever study you're trying to do, and the analytics you can bring to bear. You might you might know more than you did before. And we often see the barriers and then figure out, well, how do we go over, under, or around them?
No, I was just going to say, I think, and this is Brady Hayes from Eli Lilly, there's a lot of great questions that you can ask on the theoretical level, but if you get down to kind of thinking about what is our endpoint about increasing health, and how do you measure it, there's only 2 things that your body takes in: nutrition and rest. Those are the only 2 things that drive the rest of your energy for the day. And then you spend those times on, either reflection mentally, relationships, finance, exercise, career, or contribution. And so are we defining health? How are we defining health? And certainly physical outcome is one of those, and that's why, but we also need to think about the confounding variables. So you start breaking those things down, nutrition, the grocery stores. Are we looking at that data to really understand what's being put into our bodies? And then rest or sleep, and you can talk about Fitbits or other things, or self-reported. And then exercise, how are you defining it, right? And how are you tracking it? So I would actually say, if we really want to promote health, let's try to start breaking it down into very specific, measurable things. And I think that, from a patient or a consumer's perspective, those are the 2 things that I have. I have time, and I do that. I eat and I sleep. That's a must for my body, or I'll break down. And then the rest of my time is split among those other things.
I think that also it's really important to keep in mind about community health measures. So the built environment is what I'm thinking about specifically, more what assets are in our community to help people be healthier. So that's an important piece. And if we're looking at how we're evaluated, there are also other behaviors, and what comes to mind is cigarette smoking and alcohol consumption. And so other behaviors that also are not something we have to do, but that we do and that impact our health.
John Frank from United Healthcare. I think that we underestimate these days the power of the consumer-driven economy. A couple of examples. TV network executives tried over and over again to kill America's Got Talent and The Bachelor before they ever got off the ground. But consumers wanted those programs, and they flocked to them in record numbers. 10 years ago, the 2 political parties never would have allowed Bernie Sanders or Donald Trump to get as far as they got. But there is the consumer, action in our country and around the world for these sort of people-driven change. I would contend that the healthcare system is not a lot different. And there is a new generation of Americans that are looking and saying, look, this is what I demand. You know, I want to have my health and wellness information in one spot. I want to use Teladoc and virtual visits. I want this, and this. And there isn't a silver bullet out there right now, but that solution will come into clear view here in the not so distant future, because there is going to be a growing demand for it, and it will drive the behaviors of all of us that are trying to provide solutions, services, and technology. There isn't a strong enough consumer demand for us to change our behaviors. But when that happens, and I think it's unfolding right before our eyes, it's going really slow right now, and then it will go really fast, like so many other societal changes we've seen driven by the consumer in the last few years.
So here's my question back to you. How do we leverage that trend, which I think is a valid observation? How do we leverage that for what we are discussing here today? And how do we engage that trend to help?
You know, I suspect that there are there's a lot of people out there that are 1 person, 2 people, 10 people. They're working together in virtual groups and small companies that we've never even heard of that are coming up with these solutions. They're the ones who are going to change it. I think it's not impossible, even for a company like United Healthcare, which is also part of, Optum is part of our company. They're looking at solutions like that all the time. But I think that there are a number of nimble players out there who are reading the consumer and saying, I'm going to come up with something. And then once they start to get a pocket of followers, it will become mainstream. The bigger organizations, no matter where they be in the healthcare system, are going to pick it up and run with it, because consumers are going to start saying, I'm not going to go over there because they don't have what I want, but these people over here do. And when that starts happening, there's winners and losers. The losers are going to start saying, we have to change, we have to get on board, we have to get our data over here, we have to use the same device, we have to respond to what the consumer is saying. I think it's actually happening right now, but we can't see it because it's not on a large scale. But I think just like that, it's going to happen, and I think it's going to be within the next year or two. I really do.
And I hope those 2 people are in India.
I hope they are too.
So we have Brian, Tim, and Joe.
So I was going to say, thinking about what we do in phase 2 from this process could be defining 2 or 3 use cases where we could begin to answer and address these issues. Looking at, okay, so we brought up a lot of cool ideas, right? Everyone, I do a lot of work in public health, and everyone's like, oh, don't forget about STDs, oh, don't forget about health promotion, oh, don't forget about, food deserts. So instead of, trying to boil the ocean, as you pointed out, if we could pick 2 or 3 things that we think will be important trends or micro things that we could focus on as a group, or maybe even divide into a couple clusters to really focus on in the coming year, I think that would take us a long way to addressing the policy and consumer and business drivers and alignment and all of that, and have this conversation. So that's what I'm thinking about in terms of moving forward to help us make progress.
Good. Tim.
One of the big things that was brought up from Titus here is that we are a leader with the health information exchange that we have here, and all these different silos of data need to go into a same repository that can be linked together so that we can truly measure across. So does your fitness affect your A1C? Do social engagements, going to hot yoga, affect your COPD? Things like that. And we truly have this Switzerland already set up here where people have a trusted center where they can save their data. And your point here is that we're unique around the country for sharing data. I came from Cleveland for new medical training. Cleveland Clinic and Case Western are literally a mile apart and will not talk to each other. Here we are a very unique community for this. I sit as the director for research from the IMPC for this, so everybody has access for this. Let's get all the same data, the health data that we're already getting, the wellness data that we want to get.
I don't want those one or two people who are developing, their own app to do this and store it in their local repository. I want to have an API that allows that to go into the health and wellness center so everybody can benefit from it. And I think the key here is to continue to promote all those other companies that have data. Well, I want Kroger data in the INPC because I want to link that directly to that. How great would that be for it? I want my fitness data. I don't care who does the aggregating, but I want that data dumped in there so that we can link it across the different systems. So we already have Switzerland, and we need to promote Switzerland as the for all the companies.
So, perfect sequence, because I agree with John's point about consumers, I agree with Brian's point about use cases, and I think you're pointing out that we have an opportunity because Switzerland exists in Indiana. So I'm not saying this is the greatest concrete idea of a use case, but this, for those of you who are saying, great, you're right, what do you mean? So how many people have used what would be called a patient portal, a personal health record that's offered by your healthcare provider, your employer, or your insurance company?
I've used 4.
Stealing my thunder. How many of you find it useful to a reasonable degree? Okay, that's a lot fewer hands. How many people would find it more useful if you didn't have to look at 4 to see all of your data? Okay, so here's how ridiculous the opportunity is in Indiana. As Titus pointed out, the Indiana Network for Patient Care has all of our data normalized sitting in Switzerland. The Indiana Health Information Exchange does not offer a personal health record. The primary reason is because your employer does, your insurance company does, and all your providers do. But there is no reason that we couldn't, that the INPC couldn't be the source of the data through your employer, your insurance company, or your healthcare provider to put your aggregated data in the format that, in the platform that you would choose. I don't care which of the 4 PHRs you choose to use. If your data can be in all of them, you pick the one you want.
Good. So let's finish up with maybe a few other thoughts about the action items for the future. So Brian has kind of started us off already by saying let's focus on 2 or 3 things. I think now that we've had 2 sessions almost over, certain ideas are crystallizing. You realize, you probably noticed I take a lot of notes, so I keep a detailed log of all ideas. And so I think we have some really, really good concrete ideas. The question is, how do we change policy? How do we engage people with funding? Without money, this is not going to work. Just because we all think it's a good idea doesn't mean it's going to become reality. How do we maybe draw in the right people into the conversation, and how do we, in a year, how can we be able to say, we've actually moved the ball forward? Thoughts on this? And I'll ask the same question at the last session, if I get the moderator job again, that is. I'll ask this again. So today's not your last chance, but how do we? I think that we have a lot of good preconditions for positive change to happen. How do we make it happen?
Can I say something if I promise to shut up after that?
That's okay.
Okay. Real quick, what if we tap into organizations that are thinking about health policy already, like the Hospital Association, like the New York State Medical Association, like whoever, that aren't thinking about technology, and we as a technology contingent representing Indiana go to them and say, we want to propose a health policy discussion that includes as a huge component of that representation of technology.
Okay. One idea. Other ideas like that?
Just a little fuzzy on what the barrier is. So like we talked about policy, is it specifically because there is language that's prohibiting the sharing of this data because of personal privacy?
Oh, no, I think that the list of barriers is very long, but it's not you can overcome it. But funding is a barrier. So
I'm just trying to hone in on, if it's funding for what? If it's partnership, if it's policy, what language? You know, like, what are the barriers that we're trying to overcome?
So there's bills in the state legislature right now on telehealth and InSpec. Okay, and there's policies that could be in those bills that aren't. What are the barriers? Well, it depends what you want to talk about. So it's just trying to get concrete. Yeah, I would love to be in that discussion.
And I would add to this, we just talked about barriers a lot. Let me turn the situation with you around and say, what are the market opportunities? I think there are entrepreneurial opportunities in this whole space. To John's point, we gotta find those opportunities and gotta find the people who want to take the ball and run with it. And maybe some of them are in this room, maybe some of them are associated with TechPoint already. Maybe one of them is an extern who's coming next summer to here. So I think there's really good potential. Other suggestions?
Well, can I just, on that note,
Yeah.
one, you mentioned the extern program. Many of you, I'm realizing that many of you are not necessarily in kind of the traditional tech community, and this is an area for cooperation. So we created 2 years ago a talent attraction program to attract tech talent to Central Indiana. And we had ambitious plans. We'll grow up from 50 students to 100, and we to 75 to 100, and then over 100. And we went 50 to 108. The next summer we'll have 130. These are all software developers, graphic designers, computer science majors from all over the country. The really interesting thing is they had such a fantastic. We recruit them, put them in job, place them in job opportunities. With now 45 companies around Central Indiana. We house them, 2 members of our team to live with them, do all the nights and weekends programming. So turnkey internship solutions in order to get top talent here. The interesting thing is they've had such an awesome time in Indy. They've gone back and told all their friends. And so we had, for next summer, these 130 spots, we had 900 applicants from 50 plus universities around the country. And so I'm sure, but naturally we plugged them into job opportunities in places like Salesforce, Angie's, Interactive Intelligence, Lilly, but also startup companies and young emerging companies like Springbuck as well, that are kind of through in the traditional tech space. But we know that tech is part of most every company, and I'm sure that there are probably really interesting and compelling tech job opportunities inside many of your companies, though you may not be flying the flag of a tech company. So if that's the case, let me know, because I think that getting that talent interconnected through our companies of different industries and different types is ultimately, but then them getting knit together into a community where all 130 of them are going to be living together is part of that interconnectivity that's going to require you to create these collaborative solutions.
Yes.
I kind of try to think of the following question. So I heard a factoid earlier in the week that last year, and I think it was Gardner, whoever tracks it, that there was a lot of startups in the data analytics space. Because we talk a lot about the data, but the data will never be perfect. And yet we have yet in Central Indiana to see any of these startup data analytic companies form.
You got one 3 seats down.
Where?
You got one behind you.
So it didn't make the list. So that's why I'm asking, but you could begin.
You got another one back in the corner.
So I think that's the issue though, right, is that how do you need to marry a number of things. The questions with the data. The data is incredibly rich. So what is the limiting factor in trying to tease that signal out of the noise? And
I think, so one reason is that we don't have the right dialogues going. So Reagan Chief understands data very well because we've been working for 40 years on accumulating, connecting data, doing research on it, the work that Tim now leads. When you try to figure out who is diabetic in the INPC and who is not, you very rapidly realize, well, this is not such an easy question. And so we have statisticians who do bake-offs between different models of how you tell whether somebody is diabetic or not. this is not something a computer scientist comes in. So we have Dr. Ben Millett here, who is from electrical and computer engineering. Computer scientists don't have that inherent knowledge about what's clinical utility, what does it mean? The data is all perfect because of physics. It is, and not even there, it's all perfect. So one of the things that I've enjoyed very much, and to Mike's point, there's actually a few other data analytics companies who aren't here today in Indiana, is that dialogue about kind of cross-pollinating and working together. And I'm hoping that that's one thing that comes out of this series, is that we actually keep talking. And they're all plugged into TechPoint, which is a great community builder. So I think there's high promise there to take data analytics up a notch. Because when you look around the country, there's companies selling data analytics where you look at what they do and you're like, yawn. I did that 30 years ago in SQL on a tandem timeshare computer. So, all right, last point.
Well, I want to get to for why the data analytics it's that access to the data. So the data analytic companies want access, they just can't. And this is the Switzerland model, is that we're the trusted partner for this. So I have 14 masters and PhD level data analysts who, Brian has a nice paper coming out listing over 100 papers that have come out from this group. So it's there, it's just not available for everyone because of the restrictions. And so it's either loosen the restrictions or understand the resource that's there.
So plenty of opportunity, plenty of work to be done. I'm going to close the session because it's really important that we get to network, and if last session is an indication, it's going to be an intensive phase. So let's thank our speakers one more time.